Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with an extremely blocked left ear. They have a combination of earwax impaction surrounded and coated by a thick layer of skin. Now the skin on the outside has softened, it's macerated, perhaps due to the humidity created by this impaction. So when you've got this much wax in the ear and there's an airtight seal, you create humid conditions behind the wax plug, and that can start to soften and macerate the skin, and it can become quite gooey sometimes. And the core of the wax itself is quite dry and crusted. The patient is a hearing aid wearer. That itself can cause not only the impaction, because it can push the wax in as opposed to allowing the wax to naturally migrate, but when you've got a really tight fitting hearing aid, which this patient has got, the humidity created by that tight fitting, again, it can just soften and macerate the skin. Remove the main blockage, and they've got this, as I said, this envelope of skin around the perimeter of the ear canal wall. So I'm just going to peel this away. We got to be careful that we don't cause any clarinetting. When you're suctioning dead skin like this, the skin can violently flap at the tip of the sucker, and it creates clarinetting. Clarinetting, interestingly enough, I was trying to figure out and decipher where that term derived from, and I have to give credit to my colleague, Mr Darius Rajali, who's an ENT surgeon. I'm not sure if he developed the term himself, but I've not had anyone else use it prior to him, and that's when I started using that term to describe clarinetting. And so when you've got clarinetting of dead skin, it's always best to revert to the fine end suction probe. The fine end, it's got a narrower internal diameter, so there's less suction, overall less suction power, should I say, and if you do come in contact with the eardrum or the ear canal, you're less likely to cause any significant trauma. Also, when you use a fine end, because there's overall less suction power, it's quieter. Some patients do find microsuction a bit too noisy, so a fine end can be a good solution to that. So with fine end, yeah, you're much likely to get less clarinetting. Now, I paused before when I said with the fine end there's less suction power, and that is true to some extent, but because there's a smaller surface area, in effect, wherever you position that fine end, there is actually in some respect greater power because there's a smaller surface area. And if I've got some stubborn dead skin, sometimes a fine end works far better. Now, just in this region where we are now, this patient's ear canal really narrows. It's almost like a valley there, like a V shape, and there's a bit of crusted dead skin, which is very hard to remove. The fine end physically doesn't fit in that gap. So I do try it once again a bit later, but we've had to leave that. I'm just trying to get some of this soft, dead, shedding skin off the back canal wall, and I'm going to highlight it in a moment. There is some granulation tissue here. So granulation tissue is almost like a bodily response, a healing response, and it's a buildup of connective tissue, and the connective tissue has its own blood supply, its own blood vessels, blood capillaries, and it can give a moist, bumpy, reddened appearance, and you will see that in a moment. It's not prominent, but this patient has got a history of granulation tissue, so we'll refer them to their GP to get some medication for that. The eardrum, you may have not noticed, but it is visible, but it's very opaque. So this is the patient's eardrum. This is the back portion of the eardrum, and to the left of screen, this is the front part of the ear canal, and that's where it's very tympanosclerotic. There's a lot of scar tissue there. The front part of the ear canal where I am here, you can see it's very pronounced. It protrudes inwards, so we've got to be careful. We don't want to make contact with that bony part of the ear canal. And because of that prominent bulge of the ear canal, beyond that you have the anterior recess, so sometimes you can get wax building up there. So what I've just circled there, what I'm just indicating and highlighting, that's the granulation tissue. You can see it's a bit moist, it's a bit bumpy, you can see the blood supply there, you can see it's a bit reddened. So I'm just going back for that piece of crusted skin to see if I can remove that, but there's literally just no physical space for me to get that suction probe in further. So we're going to leave that. We're happy with what we've done. This patient has got a history of chronic ear infections. A couple of years ago, I do remember this patient having to come every 2 or 3 months to have their ears cleaned. So this is their right ear, and this side, the skin is a lot dry. This patient doesn't wear a hearing aid in this ear. So it's therefore plausible to suggest that the wearing of the hearing aid in their left ear may be a contributing factor as to why the skin is very damp and moist. So I'm just using the hook. You can see the sheet, the slither of dead skin. The patient's wife was in attendance, and they were looking over my shoulder at the screen, and they were flabbergasted by what we're removing. Now, you may believe that's a perforation or hole of the eardrum, and I did too initially. However, upon closer inspection, that wasn't a hole, it's a retraction pocket. So I'll come on to that in a moment. Now, there is a bit of macerated skin here, actually. You can see it's a bit damp and wet, but not as much as their left ear. So I'm just peeling that away. This eardrum, that hole is a retraction pocket. It's very likely that this patient previously suffered from a tympanic perforation, and that healed. So when you've got a hole of the eardrum, it can heal. So I just circle that. But when it heals, instead of having 3 membranes, you only have 2 membranes. You have the epithelial skin layer, which is the outermost layer of the eardrum, and you have the mucosa membrane layer, this is the innermost, but the middle layer, the fibrous layer, doesn't always form. So that region where you have a perforation is a thinning. So it has healed, but instead of 2 membranes, there's only sort of 3 membranes, fine, there's only 2. And that creates a weakening on the eardrum, and this patient's therefore more susceptible for that eardrum to get sucked in if they've got a blocked eustachian tube. They have already been seen by ENT about that perforation because it is quite a substantial one, it's quite a deep. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.